that you guys would have time to be able to do this in the ER, but if you did, it would be great, so that when we're the nurse accepting the patient, if you handed us this form and we could look at it and just be like, okay, we got the vitals, we got the history, we've got you know, some of the medications they received, their allergies, code status, not necessarily important at that time, but anything that could be added to this so that we could just take a quick look at it, we know that it's complete, move on. Accept the patient, get the patient on the table, get ready as quickly as possible. The nurse is responsible for all the medication, helping get the patient ready, and doing the timeout prior to the procedure. The circulator is kind of like that fourth position. Sometimes we have them, sometimes we don't. But the circulator would be also to get the patient onto the table, get everything ready as quickly as possible, and then pull supplies for the scrub and for the doctor as needed. The fourth 15 minutes, this is where we're, patient's on the table, patient's prepped, we're ready to go. We're starting our PCI, percutaneous coronary intervention. We get access, we put in our wires and catheters, we get our initial shots, we see if there's an occlusion. If there's an occlusion, it's go time. We're beyond go time. We're going even more quickly as we were when we were receiving the patient. So we see where there's a blockage, we assess if the patient needs a balloon pump or if we need to do an IFR, which is a wire that we use to assess if it's flow limiting or not. And we start giving our medications. For STEMIs, we typically just use Angiomax because if we were to use heparin, which we normally use, we don't have the time to run our ACTs. So Angiomax or Integralin if necessary. And then the balloon time stops when we have inflated our first balloon. So that's where we're going. We're getting access, shooting the pictures, putting a wire down, getting that balloon. As soon as we get that balloon, then that time stops. So that's that 60-minute period. So it doesn't stop when we're finished, it stops when we get that first balloon and inflated. So sometimes we see Takotsubo, but I don't think we've seen that in STEMIs so much. We see that with women with chest pain. I think they're mostly like non-STEMIs is where we see the Takotsubo. Is anybody familiar with Takotsubo? Yeah. We just had to?
Yeah.
Awesome.
Takotsushi.
Yeah. So those are kind of like a relief, you know, you kind of get that LV and you're like, okay, whew, it's not a STEMI. So, yeah, haven't seen those holidays, it seems. Those come up a little bit more often. Multi-vessel disease, if we have a patient that has the need for a cabbage, we don't send so many patients out for cabbage anymore. So our cardiologists are going to focus on the vessel that is causing the MI and try to fix that first. And then if there's other vessels that are affected at that time, they'll consider it. Sometimes we would just let them heal for that STEMI and then bring them back again. So cabbage would be something really serious. 3-4 vessels that are just really bad and there's not one single one that we can fix. If that's the case, we need to make that decision if the patient's too unstable for us to ship them up and send them out somewhere else. Emergency transfers. Knock on wood, haven't done this in a little while either. This is a process that we would have to then, cabbage or something really unsafe situation, get the house supervisor involved to be making those phone calls to the other facilities, Renown, St. Mary's, calling REMSA, getting everybody over here as quickly as possible to get them transferred to another facility.
I do want to bring up that a while back, we had just to tell a story, we had an opportunity, must have been 5 years ago, where we did need to transfer someone out in an emergent fashion. And one of the things that we did do is we set the cath lab staff to help expedite the transport getting there. Can call only in emergent situations EMS to get there. So we do have that phone number posted in each lab. So in the event that we need need to start getting them driving there in that emergent situation, so we would make that call. But if it's in a controlled situation, we would go through the normal process. Okay. So the other point, yes, Tiffany?
Can I just ask a question about the patient arrival? It is a valid review. Is there ever a time that the cath lab would refuse to take a patient to the emergency department?
That we would refuse to take a patient?
Yeah, to say I'm not ready or whatever the case may be.
That's a great question. Yes, the only time that we would say we're not ready, I'm not going to say that we would refuse to take them, is if we have patients on the table already. And then at that time, we would have the communication between the physician, the ER physician, and the cardiologist, and they would talk about that risk stratification and what's best for the patient.
Okay.
Yeah, so, and the choices are really simple. One is we take them off the table, expedite them off to put the other one on, or we would consider fibrolytic therapy. Now, one other thing that we, I just want to, so we're all on the same page, because that is our goal today, is, as Dan was alluding to, all the things that the emergency room staff have to do is, can be daunting in a lot of things, but using those cards, it simplifies it. Having said that, it is our expectation that the ER does bring those patients over to the cath lab. So like last night, how'd that go? Did the ER bring them over?
We did, but we called over and they refused the patient because there was only one nurse there, so they said they didn't take the patient. We called twice.
Well, that's beautiful. And that's exactly why we're having this class today, because what we're learning is we all need to be on the same page. So let's talk about that for a moment. Let's talk about that. It's not that we're refusing the patient. The cath lab team,
Giving it misses a bar time.
we need to bring
We
the
get yelled at.
patients to, the ER's goal is to bring those patients to to our cath lab. It is, we're not supposed to hold them up, okay? We can't say no unless we have another patient on the table. So this is to get us all on the same page. We want that to happen so we can help meet this door to balloon time, because we know it's going to 60 minutes here nationally coming soon, all right? So we cannot refuse it. The nurses from the ER will bring those patients over. They will bring them, help put them on the table, and after this class, we're going to ask everyone to come over to the cath lab, and we're going to show you where all those tools are, EKG leads, and how to move the table if you need to, in order to put the people on there. Now, if there's no nurse in the lab at that time, the nurses from the ER will be there. It's just that they got there, brought the patient over a few minutes before our nurse arrived. Yes?
I think what we have, what we think about is like down the road, if we put that patient on the table and there's no one else around and the patient codes, I'm more comfortable running a code in the ER than I am in X-ray. It's an unstable patient. So there's no one in the cath lab helping me, and I'm there with the patient by myself, running a code.
You know, in our chest pain meeting, we actually talked about this in a group. And we had,
You and your tech, if you're running over there.
and we had our medical directors there, we had Shelby there, we had the whole team. And really, the reason that the patient is having these situations is and coming to the cath lab because they need to get fixed in a timely fashion. And the medical directors believe the best way to do that is to hurry up and get them to the lab. Now, in the event that something bad happens, we do have our codes to call. People will be coming to help, but it is the process that we want to do, which is have the ER staff bring them over to the cath lab. Okay?
Yeah, and it's always going to be a judgment call. I mean, we talked about this in our STEMI meeting as well with a bunch of, like John was saying, Shelby and Dan,
Yes.
a couple other ER. If you feel that the patient is unstable,
Yes.
to bring over to the cath lab, or it's just you and a tech, then don't do it.
Yeah.
Okay,
It-
so when we come in as a staff member, when we're called, and we come in and you guys aren't here, that's our first call. We're calling the ER, hey, we're here. We have so-and-so and so-and-so and so-and-so here. Come and bring over the patient, if the patient isn't over there yet. And so there's been a lot of confusion about that, because it's just been brought up and we've just discussed it about what our process is moving forward. And so we have to also, because yesterday was a couple of per diems that don't work all the time, that aren't a part of these conversations. So we do need to include all of our team members in that as well, because you shouldn't have had the, no, we're not ready for you yet. So, you know, that's something that we'll, we'll make sure that that gets discussed to everybody as a team. So if you feel that your patient is unstable, then don't. As soon as the nurse or whoever gets there, then we'll call and say, we're here, you can bring the patient over.
We know that the cath lab turnaround time on their calls through measurement of data, if you will, is about 25 minutes. So we know that, once you put that foot on, the time on the foot or the arrival time, you know when our full team is going to be there. Yes, at times one person may get there before the others because they live closer, but in general, we're going to be there in that time. So to help out, and to confirm what Val's saying, if that patient's coding in and out and they're truly that unstable, yes, there are exceptions to the rule. But routinely, we do want the emergency room staff to bring those patients over, and that's why we're doing this training today. So one, we all get on the same page, we all understand how to work the equipment and where things are located in the event that these situations happen, because it could happen.
And I don't know if you guys are familiar, but if a patient has been coding and there is innovation and there is CPR, then that 60, 90 minutes is out the door.
It doesn't count. It's
It
no
doesn't
longer
count,
valid.
because it falls out of what the requirements are for accreditation. So if you are doing CPR, if you're doing innovation, take your time with that patient. They will get to the cath lab eventually, but that time frame doesn't matter. We need to do the safest thing for the patient at that time.
Exactly.
Did you have something to say, Ann? Well, I was just gonna say, really quick, as to the point of only having an RN and tech in the room. So the, health supervisors, the expectation is that we're supposed to stay with the patient at all times until we are released by the cath team. So we are the second RN.
Okay.
With the primary RN, and we're supposed to, so that's not happening all over the health supervisors for sure. Because we have like the full override capability, say if that RN, for whatever reason, wasn't able to make it or didn't come, we would be the cath lab
Yeah.
RN.
And when we go to the cath lab, we'll point out important pieces of equipment that you need. Obviously, where the code blue button is, where our crash cart is, the Pyxis, all of those things to make you as comfortable as possible. I totally understand not being in an environment where you're comfortable doing emergency procedures. I totally get that. So as
Your nurses
more
have
that you know.
access to Pyxis.
Yes, they do. It was one of the things that came up from ER nurses is they didn't at
I mean,
one
it's
time,
not a bad idea
and they do now.
to make sure, for sure, yeah. Yeah. So I mean, obviously, the more that you know and the more that you see things, are a little bit more familiar with where our things are located, then it may make you a little bit more comfortable. And like John said, I mean, we get here super fast. I mean, sometimes we're here 15, 20 minutes. A lot of us live within a 4-mile, 5-mile radius of the hospital, so, yeah. So, I mean, and it's not like we dilly-dally. It's like we get the call, we're in the car, we're off and running, so, yeah.
So again, the goal of this is to make sure we're all on the same page, we all treat the patients the right way and do what's best for them, so we could get that reperfusion going, as well as meet our times for our chest pain accreditation. I'm going to open it up for questions.
I'm looking at this slide and I'm reading the continuous peer review of cases. I think, and I've heard this, I've worked in a cath lab for a really long time, I've heard from ER staff before that it's always nice to know what happened with that patient, right? I used to work at St. Mary's, we came in through the ER, we left through the ER. And during those times of leaving, they'd be like, hey, what happened? Oh, we had a total right coronary that we said, oh, okay, cool, how did he do? Oh, he did great, you know, whatever the situation is. It's a little bit different here. So I think that this is a facility recommendation for 2019. So I think that if we had time to do those kind of case reviews more often throughout the year, that, you know, it'd be a good team building kind of thing for all of us, you know, and to have you guys have that, you know, understanding of what happened or, you know, outcome. You know, everybody wants to hear about outcomes, so I think that would be a great thing. Yeah, yeah. I mean, sometimes you guys kind of come back, I've seen you guys kind of come back and hang out, like, oh, what's going on, you know, so, yeah.
I do want to offer, at any time, anyone is welcome to come to the cath lab and see some cases. Hang out with us, see what's going on, and be part of that, or to get that understanding. So we offer that to everyone.
We're going to be seeing new doctors in the ER, and I think that it needs to be stressed also that if EMS calls and FIT does a STEMI alert, we do not wait to activate the STEMI team. We activate it at the time they tell us, and then we can always cancel it once they get there if indeed it is not.
We don't have to have clearance.
Usually I'll put it in
Right.
right. Like,
The year
That is
yesterday,
coming,
we wanted
5
all
minutes after.
first, and she left, and I said, call it in.
Right.
That's
Right,
exactly
so
right.
it's the nurse can call a STEMI alert if EMS on the radio tells us a STEMI alert.
And Dan
No,
will
it
bring
doesn't
up-
matter, it doesn't matter. I was just saying, we are not offended by being canceled in any way whatsoever.
No.
Yeah.
No.
And I want you to know, as we move forward with the sound physicians, we have created a education plan for them. And on my checklist that I go through, that every doctor that goes through, we talk about STEMIs, all the things that we just talked about today, and we do talk about EMS when they activate it for us to call it and not call them off, or just call it, as Val says. It's the right thing for the patient. Oh, good. I'll tell you what do you say we get a,
Cheryl and Kevin back there that want
oh, Cheryl.
All right, so when you think of chest pain and you think of lab, what do you think about? Because that's what I think about. I think about components all the time. I'm sorry, do you want me to move or?
You're good.
Okay. So did you know that we also have a time frame that we have to maintain a troponin in? Guess what it is?
15 minutes.
60 minutes from when the patient rolls through the door to when the result happens. How long do you think it takes my analyzers to run it? Even if I'm cheering it on, I'm like,
58
go,
minutes.
go, go.
Yeah.
It takes 23 minutes to run on my analyzer.
What about those? How accurate are those?
It doesn't correlate at all with the analyzer, and they're not very accurate. So, yeah, so we've decided not to do that. So why you are all so important is because you're telling the doctor, hey, order a troponin, because we can't do anything without an order, you know that.
Just order.
Or order the troponin yourself because you have the power. Also, if you draw the blood, we are so, so grateful. If you can't draw it, call us right away. We'll run up and get it. If you have problems with that, let me know. I'll address it. So, anybody with chest pain, not just your STEMIs, we're thinking once they roll in the door to when the result comes has to be within 60 minutes. So, currently, we're so close, we're at 66 minutes. But I think that after you all know that 60 minutes is the magic number, that we can make this happen. Unless you guys have any other suggestions on how to do that faster.
We can use, because Rebza has blood tubes from Renown.
Yes.
We can use those blood tubes.
And I'm happy to provide
boxed
tubes,
idea.
yeah, we boxed up some tubes for them as well, so if they want to draw in the field, we're happy to run those.
But if they come in with foreign-looking tubes, that's cool.
As long as it's got the right stuff in it. I mean, if it's like something
Well-
random.
This doesn't look red.
And our only stipulation, it has to be labeled with the patient's name and date of birth. I know, we're sticklers. We want to make sure it's the right patient. But other than that, 60 minutes, fabulous. If you guys need help from us or if you have other ideas, I know we've tried like stickers in the past, but I don't want to complicate your already complicated process with your competing priorities. So just let us know how we can help. And if you need a draw, you can phone thingy. Yeah, you can space phone the staff phlebotomist and they'll come right up. Any questions about lab or anything we can be doing for you? Oh, so biotin, the people that make all their hair very pretty and their skin very pretty, interferes with some of our chemistry results. So we had sent out a letter to the physicians probably like a year ago. I'm trying to recover that letter. I know Susie has it somewhere in the depths of her office. We'll resend it out, but if you have a patient who is like, oh yeah, I take biotin, a lot of it every day, my hair is beautiful.
It's actually prescribed for MS patients as part of their therapy.
Okay, I did not know that. So just be aware that it could possibly interfere with some of their chemistry results. Fun fact.
How's that interesting?
It could elevate your troponin a little bit. A lot of the HM modules on our chemistry analyzers it could affect. So just false elevations in the results. So if you get a patient where you're like, gosh, that just doesn't seem right. You're the ones looking at the patient and you guys know. You see these people every day. Yeah, treat the patient. And if there's something that you're like, man, this does not feel right, then you have every right to question it. Right? Now your second favorite ancillary service. I'm just kidding. Thanks, you guys.
Thanks, so we have drugs.
You're right.
I was gonna say dietary.
Hey everyone, I'm Kevin from pharmacy. Did kind of tell me what John and Val were talking about, like what happens if the cath lab team can't get here. Did anyone feel an earthquake last night? I did, I swore I did. But anyway, it made me think about what happens if a giant chasm opens up right on Prater, like 20 feet wide.
YouTube it. Good thing I can still get here.
How would the cath lab team? Do you guys have ladders, like
Like
crevasse ladders and stuff?
They have helicopters.
Yeah.
We have a helipad.
I was gonna plug in my laptop, but I think this might just be easier. Use the power of
Well,
Google.
Can we just FaceTime and then we'll just YouTube it? Tell us what to do.
There's
Just
a
do
video
it.
for that on YouTube.
We'll figure it out. It's fine.
That's why we're playing ahead.
Exactly. Exactly. I watch YouTube. Yeah.
So in case the cath lab team can't get here, John talked about fibrinolytic therapy, and oh man, of course this stuff. There are two. Who knows the two options of fibrinolytic therapy? Well, yeah, one of them that I'm typing in. So we have TNK, which is tenecteplase. Who else knows what else you can use?
It's really more strokes. No.
I don't hear any
Essential oils?
Lavender.
What?
Essential oils?
Essential oil.
Essential oils.
Don't get me started on essential oils.
Big prayers.
So you can use alteplase or tenecteplase. Here we use tenecteplase. Why? It's way easier, and it's different. Alteplase is different dosing than for stroke. For stroke, you use a cap of what? 90. No one gets over 90. With an MI, you have 100 as a cap, and it's based on their weight. You have two different dosing algorithms. One's a rapid infusion, one's a 3-hour infusion. Tenecteplase is much better. It's a longer acting. It's longer acting. It's more fibrin specific. and it's much easier to dose. I'm gonna do this little video, I think it's 3 minutes. Okay, so I'll do the Kevin version of this. So I'm gonna pass out this little dosing guideline. Okay, just pass those around. So T&K is the kit has a vial of powder and a vial of Swiffy. Everyone knows what Swiffy is, right? Sterile water for injection. So that's important. You can't use NS, you can't use bacteriostatic water. So you have a 10 ml of Swiffy, and then you put that in the vial, and then you draw up, you make it to 5 milligrams per mil, and then your dosing on the sheet is there. That is your patient weight, and then the dose that you give them. And it also tells you once you draw up a 5 milligram per mil tenectic place, how many mils that is from that syringe. Super easy. And I think it shows here the nurse giving it. It's not like alteplase where it's an infusion. It's a quick 5-second bolus. So here she's drawing it up. If there are bubbles, you can just let them dissipate. Don't shake it. You can swirl it. The one other important thing is that if the patient has any lines with dextrose, make sure that you flush it with saline. You can precipitate T&K with dextrose. And that's really it. Super simple.
If this happens during pharmacy hours, I think
T&K is loaded in the ED Pyxis. And we have one.
Is that a no?
What's that?
Is that a no or yes?
That's a no.
That's a no?
Say that again.
That's a no then, right?
No,
Are
the
you guys
pharmacy.
gonna come and mix is what he's asking?
No, this is like reconstituting protonics. I mean, it's you don't need pharmacy for this. And that's the point. Is it is super easy if you reconstitute it and give protonics. It's the same thing. Again, flush line contains dextrose. Sorry, the video feels like it takes forever. And we have one. Do you know why we have only one?
Because it's expensive.
Well, it is expensive, but honestly, we've never used it. Because guidelines are, if your cath lab team can make it, PCI is way better. I hate admitting that drugs are inferior, but in this case, drugs are inferior to PCI. So you just saw her give it. Want to catch that?
Is it expired quickly or is it like other medications?
It does expire.
Is it like a quicker expiring or we only just have one because we don't use it often?
We have one because it always expires,
Oh, okay.
because we don't use it.
One in the whole facility?
One in the whole facility,
And that's from the ER?
in the ER. And we outdate that one in there every 3 years. So that's it. Does anyone have any questions about thrombolytic therapy? Super easy. there was some argument whether UHS was gonna go with Alteplase. I made the argument that Tenecteplase is a much better solution, even though it does cost more, because it's faster and time is scar tissue, so. Questions for pharmacy? Sorry, I'll prepare ahead of time, make sure this is on.
If something were to happen to that one dose that we have, would we then back up to the Alteplase?
We would. But I'd rather not confuse stroke dosing with MI dosing.
Sure.
All right, thanks.
Cool, thank you, Dorothy. All right, any more questions on any of this? All right, I'd say let's go to the next.